Thank you so much for that kind introduction, Areza. Um, and it is a pleasure and honor to be here to give the Donald Chapman Honorary Lecture at this storied institution as well. And I have many friends from many years past here at the Texas Heart Institute as well. So I've been asked to speak on a topic that I have interest in at this point, and that's innovations in rejection surveillance after heart transplantation. And a lot of this is really getting down to a molecular level and seeing how we have progressed over the years in heart transplantation in terms of a detection of rejection, but also in terms of the therapies that have ensued as well. So here's my disclosure. And so what I'd like to do is start with just 3 slides, just to give you an idea of where we are in transplantation today. Well, transplantation began in 1967, actually, in December, when Christian Barnard did the first heart transplant. And transplantation began to excel after cyclosporin became available in 1982 in the United States. And you can see the number of transplants have increased dramatically over time. Well, this is an older slide, but basically we're now doing about 5,000 heart transplants throughout the world, and almost 4,000 are being done in the United States. So predominantly, most of the transplantations are in the United States at this point in time. So why are we doing heart transplantation? Well, most of the reason right now, if you look at the figure to your right, is because of cardiomyopathy. Yes, most of that is viral cardiomyopathy at best. But look at the red on the right. It's down lower than the group as a whole. We're taking better care of our patients with coronary artery disease. Well, I don't know. Maybe it's the statins, as Christy Ballantyne talked about. We'll have to wait and see about that as well. But certainly, we're doing better in that case scenario. Now, many of our patients will come to us and then say, well, now that I have a heart transplant, am I going to live forever, normal span of life? And the answer is not really. And the reason why is because there are many problems that can occur with transplantation and the anti-rejection medications, cyclosporin in particular, in addition to steroids and even the anti-proliferative agents. Why? Because they do cause cancer. And that's becoming one of the major causes that limits long-term survival in our patient population, but also because of transplant coronary artery disease, blockages in the arteries of the donor heart. And that's what we call chronic rejection, at the same time. Now, if you look at these curves, the blue curve at the very bottom represents the oldest period of time. The purple line at the very top is a more recent time. Now, we've gotten better, but most of the improvement has been in the first year after transplantation. Better techniques in terms of surgical techniques, better identification of rejection episodes, non-invasive measures to detect rejection as well. And so we've gotten better, but more or less the lines are parallel as we go on. And why? Because we really haven't addressed chronic rejection in terms of transplant vasculopathy and malignancy. And that's why we really are out there trying to find new therapies, new regimens that are calcineurin-free, meaning no cyclosporin, no tacrolimus. And we are embarking on the belatacept trials, which is co-stimulation blockade, which occur probably in the latter part of this year. We do have NIH monies for that. So we'll see where that goes, but stay tuned, more to follow on that. Well, let me now turn to surveillance after transplantation, give you a little bit of background. Now, there's a search for reliable, non-invasive means for acute and chronic rejection, and this surveillance search continues. Part of that is because the endomyocardial biopsy to which to compare biomarkers did not appear to be the true gold standard. Is there a better way to interpret these biopsies? And I'll get into reasons why that occurs as well. And finally, can we accurately surveil for chronic rejection, meaning transplant coronary artery disease, without an annual coronary angiogram? And we'll take a look at that modality as well. So I thought I would center in on these 3 areas, in terms of acute rejection surveillance, defining rejection with the molecular microscope, but what's true, what's not? And finally, looking at chronic rejection surveillance, we'll talk briefly about the cardiac eye box. So let me just start with acute rejection surveillance. Now, before I talk about donor-derived cell-free DNA, we had some work done with genome expression profiling, basically looking at genes. Now, as you know, more than 30 years ago, the human genome was discovered in terms of the 2 groups finalizing what these genes were. people were thinking, there's got to be millions of genes, but there's really only about 25,000 genes, in the human body. So, this group from CareDx actually got together and actually were able to see what genes were upregulated, downregulated when rejection would occur. And unfortunately, this was only according to cellular rejection. And so out of this 25,000 genes, they came up with 11 genes that were involved in the rejection cascade. Well, you might think that they're all rejection associated, but not really. T cell priming, proliferation, mobilization of erythrocytes, platelet activation, steroid responsiveness, and there's some unknown genes as well. But this is a fingerprint of rejection. And they were able to actually demonstrate that if these genes were present in the upregulation, downregulation, that's when rejection would actually be occurring. And so there's a big randomized trial that was done. It was called the 602 patients were randomized, half to this genome expression profiling, GEP, half to the endomyocardial biopsy group. Clinical assessments were made, usually with the echocardiography. And the primary outcome, as you can see in the bottom, was rejection with HDC, hemodynamic compromised rejection, graft dysfunction, death, and/or retransplantation. So what were the results of this trial? Well, the results were more or less superimposed. Whether or not you had the blood test or you had the biopsy, outcomes were the same. Again, I might remind you that this was a 2-year study, and the 2-year incidence of a composite primary endpoint, hemodynamic compromised rejection, graft dysfunction, death, were similar between both groups. And now we've done an earlier study at Cedars. We did what we call the early image trial, basically looking at patients who were just fresh out of transplant and those patients randomizing, because in this study, the image trial, it was more or less patients who were further out from transplant, initially starting with 2 years after transplant, then moving down to 6 months. But we started it right at the get-go, and we found the same results as well. Well, as I mentioned, this study was predicated on cellular rejection. Well, over the course of time, we know there's antibody-mediated rejection as well. Now, we're a big antibody center at Cedars. We do a lot of desensitization therapies, and perhaps later we could talk about that as well. But we needed to come up with a non-invasive test that could detect antibody-mediated rejection as well as cellular rejection. And so we all turned to DNA, of course. Now, when you think about it, the donor is coming from somebody else. We each have our own DNA specific to us. A donor is a different DNA from the recipient DNA. So what about if we could detect donor-derived cell-free DNA, in the recipient's bloodstream? Wouldn't that be great? Maybe that would tell us whether or not rejection is occurring or not. And so the idea is, can we detect cell-free DNA? And the answer is yes. Cell-free DNA is found in circulating blood. Cell-free DNA is released from healthy, inflamed, or diseased tissues from cells undergoing apoptosis, meaning programmed cell death or necrosis. Cell-free DNA can be extracted from a blood sample and analyzed in steady-state level due to a basal rate of cellular turnover. Think about it. Our GI tracts, replenish cells every few days. And when those cells die off from programmed cell death, you know what? And we can now detect that. We have the ability to do that as well. So we can differentiate cell-free DNA from the recipient, from the donor. And higher levels are seen with increased cell damage, maybe trauma, and maybe, just maybe, with rejection as well. And so has there been a trial to do that? The answer is yes. This is one of the pivotal trials that was published a couple of years ago. This is from the GRAFT Consortium. This is from the consortium from Innova mainly, and from the NIH in that quadrant in the country. And basically, this was a multi-center study, prospective, 171 heart transplant patients with a median post-transplant follow-up of 17 months. 1,800 plasma samples for percent donor-derived cell-free DNA measurement by shotgun sequencing were collected contemporaneously with 1,300 endomyocardial biopsies. So quite a bit of correlation. Histopathology data was collected to define acute rejection and its two phenotypes, cellular and antibody-mediated rejection as well, and controls without rejection. The primary analysis was to compare percent donor-derived cell-free DNA for acute rejection to controls. And what they did was they did a ratio of donor-derived cell-free DNA over recipient DNA, more or less to try to standardize, what they were finding. So I think this was a relatively good thing to do. So what did they find? Well, first of all, what they want to do is determine the natural history of donor-derived cell-free DNA. And this is what it actually looks like. Well, when you do the surgery, you get a lot of cutting. You're going to have a lot of release of donor-derived cell-free DNA, and that's what you see. But you see it comes down rather quickly, and it almost becomes almost non-detectable over time. So the amount of donor-derived cell-free DNA from the donor is very, very small at that point in time. And that's good, because if you see a rise, well, hello, maybe there is some difference. Maybe there's something going on in that patient population. And so you can see that here it's literally about 1 month. After 1 month, you can see the donor-derived cell-free DNA, if it's elevated, would really mean something. So this is what they found. The figure on your left is from acute cellular rejection. The one on the right is from antibody-mediated rejection. When you look at the figure A here, acute cellular rejection, what is important is whether or not you have ACR, acute cellular rejection, grade or equal to or greater than 2. Why? Why is 2 so important? Well, 2 is important because by definition, you have myocyte necrosis on the endomyocardial biopsy. Well, hello, that's trauma. That's basically, damage in myocyte necrosis. And we expect to see a high level of donor-derived cell-free DNA, and that's exactly what we saw here, which was really comforting that, yes, it does make sense. And what about antibody-mediated rejection? And you can see there that AMR, PAMR pathology, antibody-mediated rejection 1 is elevated as well as 2. Well, as it turns out, PAMR1 is categorized as histology or immunopathology. And the histology actually has even more activity, maybe even more so than AMR2. So we look at PAMR1H as being considered as rejection as well. And you can see with antibody-mediated rejection, PAMR2 or greater, where they're both histology and immunopathology, and we can talk about that at some point in time, is markedly elevated. So it really looks like when you have antibody-mediated rejection, you have even more release of donor-derived cell-free DNA. Talk about that in another slide down the line. Well, what was also interesting about the study is that they looked at cardiac dysfunction. And basically, when they looked at cardiac dysfunction, the more dysfunction you had, the more release of donor-derived cell-free DNA. Kind of makes sense. In this slide here, allograft dysfunction was based on the magnitude of left ventricular ejection fraction decline, as no difference, less than 5% difference, mild 5 to 10% decrease in ejection fraction, moderate 10 to 15%, or severe greater than 15% decrease in left ventricular ejection fraction in the donor heart. And you can see the more dysfunction you had, the more release of donor-derived cell-free DNA. Makes sense as well. But again, all of these things just add up to that point that we're talking about as well. Now, what about patients who are sensitized? What about patients who have donor-specific antibodies post-transplant? At Cedars, we have a whole huge cohort of patients who are sensitized. And as it turns out, patients who have AMR 0, instead of 0.02, we're up to 0.16. So basically, you could say 8 times higher. And this is an acquiescent state. The biopsy is showing nothing at that point in time. And so there is something to do with donor-specific antibody that do rise the levels of donor-specific cell-free DNA. And you can see with AMR 1 or 2, it's markedly elevated as well. So bear that in mind, too, when we talk about what's positive and what's not. And that's why we use 0.5 as our key to say, well, maybe we need to intervene or maybe we need to treat. But even at that, it depends on the scenario as well for these type of patients. So what can we walk away with in terms of donor-derived cell-free DNA? Well, donor-derived cell-free DNA demonstrated significantly higher levels in acute rejection, both cellular and antibody-mediated versus controls, and provides a framework to use donor-derived cell-free DNA to differentiate AMR and ACR. But it's difficult at times to really gauge in terms of how high those levels are. Now, starting at 28 days after heart transplant, the use of donor-derived cell-free DNA threshold of greater than 0.25, and that was by ROC curves in the GRAFT study. And that had negative predictive value of acute cellular rejection of 99%, and would have safely eliminated 81% of surveillance endomyocardial biopsies. So many programs around the country are now using cell-free DNA instead of endomyocardial biopsies. Programs like Stanford is now done, they're down to 2 biopsies in the first year. In the old days, we used to do about 15 biopsies in the first year. You might imagine. Now we're down to about 2. Here at Cedars, we're down to 6. We would be down to 2 as well, but the only reason we maintained 6 was because of the NIH trials that we're at, which mandate 6 biopsies. So after the trials are over, we're going to be pinching down even more in terms of the number of biopsies that we actually do. And there's some issues about the biopsy, as I'll get into right now. So let me switch to defining rejection with the molecular microscope. And this is intragraft mRNA transcripts. Now, there's a big problem with the endomyocardial biopsy because there are limitations of conventional histology, through the biopsy and heart transplantation. Conventional rejection histology is not always reliable, not always accurate, and has some prognostic issues. There is poor reliability, intergrade agreement, 65%, about 2/3 agreement when there is rejection. In one of the big studies that was done, the Cargo-2 trial, basically when they had 3A rejection, meaning myocyte necrosis, that was the old standard scale, there was only a 28% agreement for rejection. That's less than a coin flip. And so there are some issues about standardization of what is rejection, what is not. You can see the kappa score is very low, 0.39. It has modest accuracy, limited correlation with severity of clinical syndromes. Yeah, we see what we call biopsy negative rejection. Basically the ejection fraction has fallen from 60% down to 20%. We do the endomyocardial biopsy and we see nothing in terms of rejection. That's what we call biopsy negative rejection. And that's why there's not always a correlation to what we see on the biopsy to the severity of graft dysfunction. And there's no prognostic value, provides no information on future rejection risk. And so why is this problem occurring? Well, it's occurring because there's a lot of artifact that we do see. The endomyocardial biopsy, when we go in to do a biopsy, tends to go in the same position, right through the tricuspid valve to the same area on the septum. Well, what we believe to be the septum, sometimes we may get free wall, sometimes we'll get fatty tissue, adipose tissue. I've not seen liver tissue yet. Maybe some of you have, but nonetheless, we've not seen that issue. But you might imagine we go to the same site and we see old biopsy site, and that kind of looks like rejection because that's repair. You see a lot of inflammatory cells. And so that's a big issue. Infection, CMV, cytomegalovirus infection, toxoplasma, can show lymphocytic infiltrates as well. And yeah, we've actually picked up toxo in our patient population. Actually, initially we thought it was rejection. We were treating with high-dose steroids and oops, then we found the cysts and the toxo cysts. Very problematic as well. So we shifted gears to treat the toxo. Patient did okay, fortunately. And there's something called Quilty effect. That's some endothelial lymphocytic infiltration, and it looks just like rejection. And in fact, some might agree that maybe it is a form of rejection, but it does not cause any compromise in terms of the cardiac function. And it was described by Margaret Billingham and from a patient by the name of Joseph Quilty, hence the name Quilty effect. But at this point in time, we don't believe it is, but it can mimic rejection, at the same period of time. So do we have an alternative, not only to look at the biopsy, because, the biopsy is just very much subjective, the eyes of the pathologist making that call. And so what if we actually looked at the biopsy itself? And this is called intragraft mRNA assessment of rejection. This is molecular phenotyping that offers a possibility for increased accuracy in diagnosing and treating pathologic states. Traditional histologic methods are often subjective and results are qualitative. By relating gene expression to disease states, a system can be created to diagnose, pathologies. In other words, what's going on in the biopsy? What pathways are being, ignited and active, upregulated. And so Phil Halloran at the University of Alberta devised such a system for identifying rejection and allograft injury using these intragraft mRNA transcripts, and he called it the molecular microscope diagnostic systems. So how does it actually work? Well, we have microarrays that analyze mRNA in biopsy samples suspended in RNA region, meaning RNA lather. A machine learning builds algorithms that assign probability of disease states known as classifiers. Now, we're not looking at just simple genes. We're looking at pathways here. So a classifier algorithm uses multiple gene expression values in contrast to traditional simple gene sets. The new biopsy results are compared to a 50 nearest neighbor in a reference set. And I'll show you about that as well. So what are these classifiers all about? Well, the classifiers really represent the T-cell mediated rejection and antibody mediated rejection. So we can really identify what pathways are being activated. And yes, there's some overlap as well. In the T-cell landscape, there's CTLA-4 signaling. This is co-stimulation activation. T-cell receptor signaling, dendritic cell differentiation, and interferon gamma mediated effects. And you'll see that again in antibody mediated rejection as well. But in addition, you'll see natural killer cell signaling, endothelium activation, leukocyte extracellular interaction, and the interferon gamma, as I mentioned before. But these are classifiers. And so how do we actually put all this together? It's called archetype analysis. Archetype analysis will estimate the probability of no rejection, quiescent state, T-cell mediated rejection, antibody mediated rejection, ABMR, from a single endomyocardial biopsy sample. Archetype analysis is an unsupervised method that assigns each biopsy a score based on its similar archetype analysis in an unsupervised method that assigns each biopsy a score based on its similarity to cases in the reference set. And the scores can add up to 1.0. 1.0 basically is 100% in terms of, yeah, your patient truly has antibody-mediated rejection. Now, when we looked at this, this could be looked at not only in heart transplantation, but looked at in kidney, heart, and lung transplantation as well. So the idea is, do you actually see the same pathways being, analyzed here? And this was a nice study that was done early on, looking at kidney on your left, heart in the middle, lung on your right. But 1,200 biopsy samples in kidney transplant, and you can see what represents certain pathways. You'll see in red represents T-cell mediated rejection, in blue antibody mediated rejection, and then 3 is quiescence. So basically, we can tell differences in all these different biopsy samples, and they look alike. So the same samples are being activated, or same pathways are being activated. And you see we just have a lot less biopsy samples in lung as well. So basically, we have same pathways being activated no matter what the organ system is like. And so the InterHeart study was developed, and that basically was all the heart transplant programs getting together to see whether or not this was a true entity or not, could really tell us whether or not rejection was occurring. This was a prospective validation of the molecular microscope in heart transplant. It was assigned molecular scores of T-cell mediated rejection, antibody mediated rejection in a reference set of 200 biopsies. And it created molecular classifiers that predict antibody mediated and T-cell mediated rejection. And so this was a standardized scale that we came up with. Basically, it's looking at whether or not there's rejection and also looking at injury pattern. Now, I'll get to that injury pattern because I think it's really important to look at as well. In rejection, basically, you could elicit no rejection, T-cell mediated rejection, antibody rejection, injury, as I mentioned before, and then maybe some minor changes. And that was more or less the gray area, whether or not rejection was there or not. And then the injury scores that you can see up here, no injury, early, late, severe, early to moderate. And it's the late and the severe injury scores that actually lead to more cardiac dysfunction. So if you see those type of findings on your biopsy, those are the ones that basically are scarring that you see. And if you see a lot of scarring, that could even lead to, restricted cardiac physiology, microvascular disease, and that actually has poor prognosis when that should occur as well. So how does it actually look like? Well, this is what it looks like. These are what you see, all these dots up there. They're the reference set, and different colors, for this portrayal here. In gray represents quiescence. In blue represents antibody mediated rejection. In red represents T-cell mediated rejection. And in turquoise represents injury pattern. So for the first time, we can actually state what's going on from a molecular standpoint, mechanistic standpoint in the biopsy itself, as opposed to just reading it with one's eyeballs and trying to make a diagnosis here as well. And so this is a reference set. So when you get your patient sample, and that's in the orange triangle. So the orange triangle represents your patient's biopsy, which the mRNA transcript suggests, in this case, antibody-mediated rejection with high probability. And you can see it's really socked in on all those transcripts, the blue dots for antibody-mediated rejection. And this is 1.0. So basically, it's a definite call for antibody-mediated rejection. And this is how we use this test to really give us an idea whether it's antibody-mediated rejection or cellular rejection. And why is that important? Well, we treat them differently. We'll go with, very aggressive anti-humoral therapies when it's antibody-mediated rejection, and more steroids when we do deal with T-cell mediated rejection, or maybe even cytolytic therapies with anti-thymocyte globulin at the same time. So it really does make a difference in terms of how we treat our patient population. Well, how can we actually relate this to real world in terms of, does using the molecular microscope make any difference? So I'll turn now to my colleague, Luciana Patena. And Luciana did some very interesting studies, basically using the endomyocardial biopsy and the molecular microscope at the same time. Let me just go right on to that. And so basically he took 281 biopsies from 131 patients. And these were patients who were basically, some were early after transplant and some were like years after transplant. They had a biopsy done because it was for cause. You can see that 350 months after transplant. 34 females, 26% females, 52 years of age. Just to give you some background, most of these biopsies were done in the first year after transplantation. And so what did he actually find with all of this? He found something very interesting because he graphed out all of these issues. Now, if you look at these colors here, the blue line represents T-cell mediated rejection. Yeah, you'll see that in the first year, the first few months usually, and then it kind of steadies out at about 10%. Now, in yellow is the antibody-mediated rejection. Yeah, you get a big surge in the first year, and then gradually it starts to creep up as more patients develop donor-specific antibody. But look at this red line. This is the injury pattern. And this injury pattern you see early on, in the first year, actually, you might say in the first few months after transplant, and then it just dies away. Well, what about this injury pattern? Because histologically, this injury pattern looks just like cardiac rejection. And so Luciano took a look at this pattern because you want to see whether or not the transcripts were being elevated. And in the first month, yes, the transcripts were being elevated. After 1 month, the transcripts were actually being decreased, decelerated more or less. And so we know that injury pattern occurs in that first month, and we see a lot of rejection in that first month as well. And so the question is, are we really seeing rejection in that first month? The bright red that you see is injury. And if you look at the 2R rejection incidence here, that's what the pathologists were calling. About half of those that were called rejection, meaning 2R rejection, myocyte necrosis, were actually injury pattern. They were probably overtreated, not necessary to do that. And yeah, you can see pink means antibody rejection. Now this is cellular rejection. So you've seen some activation of the humoral aspect as well, but predominantly these were ones that you see T cells invading. Now, what about antibody-mediated rejection? I mentioned that in PAMR1H, you see a lot of pink here. That's antibody-mediated rejection. And that just substantiated to us that the 1H really is important and really does represent rejection per se. Now, look at PAMR2. The bright red again, maybe about a quarter to a third of those calls are injury and not necessarily rejection. So we don't really know whether or not we really needed to treat those patients at all. So what do we do right now? We have issues in terms of our patient population, without having cardiac dysfunction. Because when you have cardiac dysfunction, you're going to treat anyway. But asymptomatic, we see this type of pattern. With injury, we do not treat these patients. So, it really has helped us a lot for that. Now, what about using cell-free DNA with the molecular microscope? We have two different modalities to actually, treat these patients. So we taking a look at these patients between 2016, 2017. We had 16 biopsy samples from 10 patients who had donor-derived cell-free DNA and endomyocardial biopsy where we had the molecular microscope. And we used cell-free DNA levels greater than 0.5 to make sure that that was positive, and whether there was a greater probability of 0.5 that there was AMR or ACR by the molecular microscope. And I'll just look at this column and look at the row on the very bottom, rejection and donor-derived cell-free DNA. There was a correlation of maybe 71% for the endomyocardial biopsy. And so we think that the biopsy may be overcaused in many cases. But when you look at intragraft mRNA transcripts, it was 100%. And so maybe, just maybe, we have a better, gold standard using cell-free DNA and using intragraft mRNA transcripts, because they do correlate very well together in terms of activity and in terms of outcome for these patients as well. So stay tuned, more to follow on that as well. And finally, let me turn to this chronic rejection and the cardiac iBox. And I talked a little about this iBox because it represents artificial intelligence, machine learning. And maybe, just maybe, this is the direction that we will all be going in the future as well. So what is this cardiac iBox all about? Well, it's about data. It's about big data, taking into account all the data that we have from demographics, but also maybe some in the first year after transplantation to give an idea of what's going on with that specific patient. When you see up here, we have clinical data, a lot of clinical data in terms of how the patients are doing, whether there's cardiac dysfunction, whether there's arrhythmias that are occurring, high blood pressure, a lot of the phenotypic findings, immunology, in terms of what T cell subsets are present. We can look at biology, troponin levels. We can, a lot of patients, have troponin that we actually do see as well. Non-invasive biomarkers, cell-free DNA, gene expression profiling, as I mentioned before, and histology, all the biopsies together. Well, wouldn't it be great if we can take all of that data together and then use machine learning and artificial intelligence to really hone down on this and to use specific statistical methodologies, collinearities, performance, discrimination, calibration, validation, competing risks, adaptability, and putting that all together, what for? To diagnose risk prediction. Can we actually do that? And the answer is maybe so. And so we did a study with Alexander Lupi from Paris. And this was, if you know Alex Lupi, he's really a prodigal child, so to speak. He's really brilliant and has a statistical background as well. He's a nephrologist and has actually helped us put together the cardiac iBox that you see. So this was a big study that we had done with Alex. And so in France, where they have a lot of data because it's nationalized health insurance, they had data from La Pitié and they had Pompidou, and these are two big medical centers in France where they have a lot of data. And so that was the discovery phase. So can you use big data to determine who's going to develop transplant vasculopathy? But he needed to have a validation data set, and that was Louvain in Belgium and Cedars-Sinai in the US. Why? Because we both have large number of patients and big databases, that we can compare. And so not only did we take into account the baseline data, but we took in first year data, all the endomyocardial biopsy samples and the first year angiogram, because that does set the stage for whether or not you're going to develop transplant vasculopathy down the line or not. And so there were some differences, though, between Paris and the US per se. This is the statistical package that we use, the latent class mixed modeling. And basically, you see here all 1,301, trajectories. But when you look at it using this latent mixed modeling, we'd actually basically look at it in clusters. You can actually cluster which ones are coming together, and you can actually, through the statistical arrangement, patients are given a likelihood of belonging to any one of these latent classes. And so in this manner, we can actually predict trajectories for our individual patients that we see. Now, there were some differences that I mentioned, and the big differences between the two groups in terms of recipient age. In the US, we tend to do older recipients. But look at this, when we looked at donor age, donor age is much higher in France, 45 years of age. Cedars-Sinai, 34 years of age. So it's a big difference, about 10-year difference. There's more donor-derived, or I should say donor-transmitted atherosclerosis that occurs. That's why they actually see more transplant vasculopathy. So we'll bear that in mind as well. All right, so what did they find in terms of the Paris cohort? 4 trajectories. If you look at trajectory 1, the latent class 1, the line is flat. Now, there's a little uptick you can see at the very end of that. But basically, if you're in this category, you're not going to develop transplant vasculopathy. Leave them alone. Don't do angiograms on these guys, as long as they continue to do well. And that was 54% of the patient population. Huge numbers. Now, let's look at category 4. Let's look at the worst category. These patients have some vasculopathy early after transplantation, but you see their curves continue to rise. And this consisted of 15% of the patient population. So this is a lot of patients, but at the same time, you can really center in on that 15%. Blood pressure control, diabetes control, everything control, compliance, as well. And so how did this work out in terms of the validation phase? Now you can see the Belgium on your left, Louvain, and Cedars on the right. Well, let's look at the right. In category 1, we did take it out to 10 years, by the way, and the same. Basically, these patients are going to do great. And in Cedars, 75% of our patients are in that category, as opposed to 54%. But remember, our donors are younger. So I think that's really the reason why, we like to think we're better than France, but probably not. It's basically the categories of donors as well. And you look at category 4, the same thing. You see a rise. And that's only, instead of 15%, we're down to 6.6%, at Cedars. So what do? We really hone in on that patient population, giving them extra, TLC, if you will. What have we done with this finding? We don't biopsy. I mean, we don't do angiograms on our patients who are in category 1, and we leave them alone. Well, I should take that back. We decided that we would do some checks, so we do maybe an angiogram every 5 years on that patient population, just to make sure that we haven't missed anything. But so far, we seem to be right on in terms of that data. All right. So what's making the difference in this patient population? Well, this is univariate analysis. So all of these factors could be contributing, to our findings. But using multivariate analysis, we came up with 6, variables that were mostly responsible for what we were seeing. 3 donor factors, 3 recipient factors. The 3 donor factors: age. For every 10 years, as you get older, increased risk. Male gender, of the donor, and smoking, But, in France, they still smoke like chimneys sometimes. So, maybe that has a lot to do with it. We think, rightfully so. Now, what about the recipient factors? Well, 1 year post-transplant LDL greater than 100 milligrams %. And so, lipids are still coming up as being an issue, even though patients are on statins. Immunology. What really became present was class 2 antibodies. Not class 1, but class 2 HLA-DQ antibodies became a risk factor. And the additional factor was episode of first-year acute cellular rejection. Interestingly, not antibody-mediated rejection, but cellular rejection. And there's a lot of data right now that is really supporting that idea that cellular rejection actually causes even more harm to the vasculature than antibody-mediated rejection. And so we know that to be a fact as well. And so what did we do with all this data? We actually came up with an online calculator. And so now, if you like, you can actually take a look at this and see whether or not your patients are at risk as well. We don't have this up and running yet, but, soon to be. But when we looked at this calculator, we'll give you an example. Here we have a donor age of 36 years of age, donor gender, female, donor tobacco consumption, yes. Recipient cholesterol, greater than 1 gram per liter, no. Class 2, no. CAB grade 1 at year 1, no. And episode of acute cell rejection, no. And most programs now are reporting cellular rejection like 10 to 15%. And so most patients are not having cellular rejection. So they're in this better category, if you will. And so when you plug all that data in, what do we find for this patient? Well, the cardiac vasculopathy trajectory of this patient is mostly characterized by trajectory 1. The predicted CAV slope per year is somewhere in the realm of 7%. So we can deal with that. 93% chance that there's going to be no transplant vasculopathy. And as it turns out, this study actually not only predicted transplant vasculopathy, but also predicted outcome in terms of survival. And so if you were in trajectory 1 or trajectories 2, you had a 10-year survival of about 80%. Well, if you look at that slide I showed you at the beginning of this talk, 10-year survival is about 50%. So why is this so much better? Trajectory 1 and 2. Remember, this is conditional survival. Survive to 1 year to do that angiogram. And so that's why these numbers are really high. But if you look at trajectory 4, it's down to 51.9%. And so there's a big difference. Yeah, these patients don't survive as well unless we intervene in the right way. Maybe so we can do something about that. But let me just take this one step further, because What's happening right now is whether or not we can use the iBox as a surrogate marker for long-term outcome. You know, the kidneys have done this, and Alexander Lupi is a nephrologist. Basically, he's done the kidney iBox as well, and it's being evaluated by the FDA at this point in time. When he has taken previous studies that were done, more than 10 years ago and applied the kidney iBox, they come out with the identical same outcomes. And so, they're stating that they can use the iBox to actually predict long-term outcome. And think about it. If industry doesn't have to take studies out for 10 years, they would save hundreds of millions of dollars by not having to do that. And by the way, what happened 10 years ago is old news. We're on to something new. And so maybe we can use the iBox to actually be a surrogate marker for long-term outcome, really maybe save lives and maybe, get industry to do more studies because we can predict longer-term outcome for this patient population. So in summary, the use of cell-free DNA to detect rejection may be an alternative to the invasive heart biopsy. Intrograph mRNA transcripts may be a reliable adjunct to determine rejection in heart transplant biopsies. And precision medicine, the use of artificial intelligence, machine learning, may be utilized to predict cardiac allograft vasculopathy trajectories in heart transplant patients to customize immune therapies. And of course, the future of heart transplant will rest on further understanding of genomic molecular science, such as cell-free DNA, such as intrograph mRNA transcripts, and further understanding of precision medicine. So from sunny Southern California, thank you so much.